Hey guys, come on in, come on in, come on in. It is Tuesday. That means it's time for some education regarding fitness. Come on in, come on in, come on in. Welcome, 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 welcome. Come on in, guys. It's a great night. We've got a great topic. 45 minutes, get you in, get you educated. This topic tonight is so popular, guys. It has got over 240 people that have actually signed up for it. We'll probably get about 50, maybe 50, 60 people that will actually show up, but you know it's been recorded. So if you don't catch it tonight, it will be emailed to you tomorrow, I believe. And a lot of people are listening to it later on. Before we start, because I really want to hit tonight hard, my name is Jeff Howard, and I have the honor to be with this panel tonight. Sarah is actually en route to a convention called URSA, so she was unable to be here tonight, but I am so glad I'm here because we were doing some talking before you guys came on, and these people are smart. I don't know how I got the gig tonight. But before we start, like always, I would love everybody to look at the very bottom of your Zoom screens. Right now, everybody's muted because if you all were talking, it'd be very loud. Stop video. Videos are kind of stopped because it's kind of, I don't know why. Security, that's in case you get out of control. Participants, but what I care about most is the chat button. I would love for you to open up the chat button, and I would love for you to type in your name and where you're from. And during tonight, I definitely want you guys to feel free to ask any kind of questions you might have, because if I don't answer it, the panel hopefully will. But let me know where you're from. Come on in. Don't be shy. Don't be shy. Oh, we got Charlotte, Atlanta, Germantown. Good. Albuquerque, Ontario, Charlotte, Montreal. Ooh, a lot of Canadians. I love this. Knoxville, Missouri. Good, 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 good. Awesome. Guys, you guys are from all over. Thank you so much for joining us tonight. Canton, Ohio, California. Wow. Okay. Before we start, also I want to thank Adam. He's from SCW. He's actually manning this for us, so he's helping us take care of this as well. I'd also like to know how many of you are group exercise teachers and how many of you are personal trainers. So just type in what you are, and if you're both, great. Just put PT and Group X or GFI. Just let me know where we're at. So good, both. Good. Perfect. So we've got a lot of Group X, we got a lot of PTs, we got both. Good. That helps because I want to make sure that when we're talking to you guys that you're getting the information, and I've gone to things before where they've spoken over my head and I didn't understand, but I was too embarrassed to let them know I didn't understand. I don't want that to be the case tonight, okay? So let's go ahead and dive in. Before we start though, I am going to have my panel actually introduce themselves. So I'd like to start with you, Sarah. Let them know who you are and where you're at.
Thanks, Jeff. Hi, I'm Sarah Zahab. I'm a registered kinesiologist and a clinical exercise physiologist. I've been working in the industry for over 22 years, and I own a multidisciplinary clinic here in Ottawa, Canada.
I love that. Great. And then we have Dr. Colin. Tell us.
My name is Colin Templis. I'm a physical therapist in Sacramento. Got my doctorate of physical therapy at Touro University, Nevada, in Vegas. Went out to Chicago, was working in Evanston down the street from Northwestern, and then came back home to Northern California a few years ago.
Love that. And then last but definitely not least, Mr. Brian, who I know because we've done these before. Tell us, Brian, who you are and what's going on.
Yeah, Brian Bettendorf. I'm in the Bay Area in California. Backgrounds as a clinical exercise physiologist. Been in the industry now for, it's hard to believe, over 30 years, and used to own some physical therapy and fitness centers. And yeah, it's great to be here.
Awesome. Well, I'll tell you who I am. I'd love for my panel to write in their social medias, how you can get a hold of them, either via social media or how they'd like to get a hold of. I hope most of you know me. My name is Jeff Howard, and I've been with SCW for a very long time, probably about 25 years. I'm in charge of their Group X certification, Aqua certification, Pilates certification, yoga certification. I have a degree in kinesiology, and we're live, guys. So if you haven't gone to a Mania, please look at the schedules. We're back, and we're doing it really well. This weekend, we have our Aqua online. So we're still doing our Zooms, and we're also going live. But enough about that. Tonight is all about saving your shoulders. The shoulder is one of the most complex joints in the body, consisting of many tendons and muscles that must be function together to work efficiently. Due to this, shoulder injuries are common, but can also be hard to identify early. Join our panel of experts as they examine the anatomy of this intricate joint and share how to train correctly to prevent repair shoulder injuries. So let's just dive right in. What are some of the most common shoulder injuries you see? Sarah?
Yeah, well, I think in my practice, we often see rotator cuff injuries and injuries due to muscle imbalances and compensatory patterns. That's sort of typically, misalignments. Those are the typical things that we tend to see.
I love it. And how about you, Doc?
Same thing, a lot of rotator cuff injuries, especially as we get older. The rotator cuff kind of degenerates and loses its strength and becomes more problematic and painful. Also a lot of like muscle imbalance injuries, especially in the last few years with people more on Zoom at home with their home office and kind of not as great ergonomics kind of creates more of those muscle imbalance injuries.
When somebody comes to you that has a rotator cuff injury, what do they point to it? Where are we at?
So rotator cuff, it's actually 4 different muscles. A lot of times docs are like, hey, you have a rotator cuff injury, and we think it's just one muscle. On the back of the shoulder, you have one right off the top here, the supraspinatus, which is the most commonly affected. Then below is the infraspinatus, teres minor, and then your subscapularis is kind of coming out from underneath the armpit. Those are the 4 rotator cuff muscles, but like 80% is supraspinatus involved. So
I love that. And Brian, would you agree this is the same thing you're seeing, or?
Yeah, I think the one that I think is included in what they were saying, but wasn't called out specifically, or any of the impingement issues. So I think we'll see impingements or anything with an itis after it, right? Any of the inflammatory conditions.
I love that. I love that. So how can we prevent shoulder injuries? How can we prevent these? Brian, do you want to say, how would we like to prevent these? How do we prevent shoulder injuries?
Yeah, so I think if we're talking about atraumatic shoulder injuries, because on traumatic ones, like somebody falls down and breaks their arm, like there's just not too much we can do about that. But on the atraumatic ones, I think the shoulder is going to be no different than any other body region, in that what you're working on doing is trying to build, comprehensive capacity to be able to tolerate what they're going to do. And that will be on an individual basis. So if the comprehensive capacity that I need to build in my grandmother's shoulder is very different than the capacity I need to build in my, teenage athlete shoulder.
Got it. Got it. Would you like to add to that, Dr. Collin?
Yeah, I think it's important to do some targeted exercises, especially for the rotator cuff and the periscapular muscle, so mid trap, low trap, serratus anterior, because our brain is really good at, without us really realizing it, hey, we have a problem going on with some muscle or our muscles are getting weak. Well, we're just going to compensate and recruit other muscles to make up for it. And we do that without noticing it. So I think doing targeted muscles to specifically hit those weaker muscles is real important.
And Sarah, how about you? How do you like to prevent shoulder injuries?
Yeah, I think in terms of prevention, it's important to stay within our threshold and our capacity to ensure that we're not moving above and beyond what we are capable of, and really sort of assessing, to see, are there any imbalances, or can we fill in the gap to ensure that we have a really stable and robust shoulder? Are there any cracks in the foundation that we can sort of work on? And once we work on those isolative or activation-based exercises, can we integrate and tie everything in so that everything's working well as a whole? Can we ensure that we have clean movement patterns?
I love that. So we're talking about, what are some of your favorite exercises then for this? What are some of your favorite exercises? Top two or 3. What do you like, Sarah?
Ugh. Well, it depends. It depends on what the person is. We have a video library of over 800 different exercises, so I can't pick 2 or 3. It's really hard. But if we're working with rotator cuff, I think very commonly we see these sort of external rotation based exercises, and this is going to work primarily teres minor, but we don't often see a lot of tears and teres minor or injuries. It's often like an infraspinatus or a supraspinatus based injury. So, being very specific with what we're seeing in imaging or assessment or history taking a lot of scapular stabilizations. I'm a big fan of retraction. And prior to activating some of those weaker muscles, I really think it's important to down-regulate overworking areas. So if we're seeing a lot of upregulation in pec, in upper trap, in levator, spending some time rolling, stretching prior to, and then working those inhibited areas can be beneficial.
I love that, Dr. Collin.
Yeah, I like to start, just based on being a physical therapist, I see people that have had injuries or are coming off surgery. That's just the nature of the profession. So I like to do a lot of those external rotations down at the side, kind of going off what Sarah's saying, because I want to kind of down regulate that upper trap. And, for my patients, if they're doing external rotation up at 90, they're going to shrug the shoulder and use the upper trap because they're just not strong enough there. So I want to get them stronger down low, or when they're not fighting gravity as much and they have some more support. So that kind of building off what Sarah said, I can kind of build that base and get them stronger without pushing them too far where they're going to compensate and use the upper trap and other muscles.
Brian?
Well, if you're going to limit me to 2 exercises, I do some version of a push-up, whether that's on the ground or an elevated push-up to deload it a little bit. And as they do it, I'd want to get full scapular movement. So I want to go into full retraction as they lower, and then as they come up, I want those scapula to spread apart as far as they can. And then the second one would probably be an inverted row, right? With elbows held in a little bit, again, working on that full range of motion through the shoulder blades also.
Okay, I'm going to give you one more exercise, Brian.
You want me to go 3?
Yeah, I'll let you go 3.
Well, we'll try and go something maybe not very common then, just to push the boundaries a little bit. Maybe some type of just hanging, getting people used to that load or that distraction through the shoulder joint, which is going to get that rotator cuff to work really hard and puts people in a position that they're often not used to going into.
I love that. And remember this, guys, a lot of our Group X people, it's the way you lay your exercises. Because you have a group of people, just remember what your outcome is. And so the shoulder girdle, of course, is what we're using to assist with everything we're doing. So you probably don't want to hit that really hard at first. You want to do that maybe at the very end if you even need to, because if you want them to do chest and back in a group setting, you don't need to specifically do it sometimes. Do you guys agree with that on my panel a little bit? You have to look at the whole picture.
Yeah, and Jeff, as I'm thinking about like a group exercise environment, I think one thing, if I wanted to change up to that 3rd exercise, might be something like going into a quadruped or a downward dog type position, doing like a bear walk, right? Like, so where we're loading that joint, getting that compression, which is going to get that rotator cuff to fire, and then having to move through that can be really helpful.
I love that. I love it. So that was how to prevent shoulder injuries, but let's talk about now they come to us, personal training,
Yep.
Not in a group setting, and they're saying, I have this now. My shoulder is da 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 da, and I want to make it not be as painful. First of all, how do we assess it? And then where do we go from there? Sarah, you were talking about you have how you kind of handle that.
Yeah, so we typically start off with, thorough history taking, but also utilizing manual muscle testing so that we can really get a specific idea as to which muscles are firing and firing well. And then also taking a step back and looking at movement screens. So how are they moving? And you don't need to have all of these specific tools in your toolbox. We can really just take a step back and look at movement, analyze the movement and the pattern. So if you're seeing that in a throwing pattern, they've got excessive scapular elevation, or they're not utilizing, the hips and core sufficiently, how can we sort of, break that down and look at that and then work to program purposefully from there?
And then Brian, I'm going to go with you next, because I know Doctor has a whole different way of looking at it.
Yeah, sounds good. It has me thinking about a fellow Canadian, Sarah, a guy by the name of Greg Lehman, who's a physio. And I think he has a super simple rubric, which is, 2 things you're going to do when you're working with somebody. You're either calming stuff down or building stuff back up. And then underneath those 2 things, there's just the world is your oyster, right? And we each have our own kind of framework that we believe in, but then there's also what the person in front of us has a belief in. And so I think some of this is trying to match what the person that you're working with, what they believe is going to work, and the tools that you have and how you map those two together. And I know that's a little bit of a 50,000-foot view idea, but I think sometimes we want to take this really simplistic view and realize that at the end of the day, the stuff it can be complex, but it's not that complicated.
I love that. And Doc?
I think, yeah, it starts with kind of what do they want to be able to do. And, I work with a lot of people who, I work with the whole kind of continuum of that high school athlete or college level athlete all the way to the 80-something-year-old who just wants to be able to reach her arm overhead or sleep at night without pain. So it's obviously going to be very different throughout that continuum. But let's talk about like the high school athlete, because that's probably a little more in line with the people that you're seeing in personal training. I like to see first kind of figure out what do they want to be able to do. And then I'll go and look at the scapula and make sure that that's properly positioned and we don't have a ton of winging, which is kind of like if these are the scapulas, if one's kind of tilted like that, or both of them really, that shows me that they have kind of a weak foundation in that serratus anterior, mid trap, low trap. So that's what I'm going to kind of start with there, is building that strong foundation, because if they don't have that strong foundation as they're moving their arm up overhead or to the side, that's going to change how that shoulder blade sits there. And then if that's not in the right position, that's going to change how the ball fits inside the socket, in the positioning there. So that's where I'm going to start and kind of go from there.
I love that. I love that. Diana asks, what do you guys think about walking plank push-ups? Walking plank push-ups.
Sounds great.
Depending on who that's
Yeah.
for, right? What do you
Yeah,
think?
if it's within their threshold and capacity, sure.
Yeah, I agree. I like it for that more athletic person who can do all the functional activities that they need to do throughout the day, and they want to do some of that closed chain stability stuff.
I love that. And then somebody just asked, can we talk about functional exercises for tomorrow, 50 plus people? Functional exercises for 50 plus people. And let's face it, I think Brian had said this prior to you guys coming on about just that. I mean, people that just want to reach something from a cabinet, that maybe is not our athletes. What do you think of functional exercises? What do you recommend? You want to start with it, Brian?
Yeah, sure. So I think by the term functional, it depends on, it's going to be context specific. So what is it they want to be able to do? And I think based on that, you're going to map your exercises to those to some degree. Although, again, there's sometimes this gap between specific versus general exercise. Like at some level, just getting them to exercise is going to be helpful. And then you can add in some specific activities that mirror what they're trying to do that will help them. I think as I start thinking about working with older adults, of which I'm starting to fall into that category a bit more, is that I just don't recover like I used to. Like tissue just doesn't heal as well. And so what I'm finding is that as much as I might be able to maintain intensity at times, it's the volume of work that's going to get me. And so again, I think this comes back to a programming issue. How do we have to modify programming on frequency and sets and reps and overall volume as we get older? And I think it decreases no matter what.
I agree. And Kathy, I don't want you to misinterpret. We're not saying that they were talking about athletes, perhaps thinking of, sometimes we use athletes as people to take our class. Like I call my people in my class athletes. But no, I think that regarding shoulders, we've seen so many frozen shoulders and whatnot with our more mature population or active agers or whatever you want to call them. Like Brian just said, I'm 58 and I tend to have shoulder things happening now with me as well. So I think that it's important that we do functional training with it. What do you like, Sarah? Talk to us about it.
Oh, I'm such a big fan of utilizing the wall as like a biofeedback tool. So whether that's like a snow angel or the wall scap raises, where we have the element of working the scapular stabilizers and some of the rotator cuff, but we also have an integration of the alignment, and we're using the wall to really help us find that optimal alignment, ears over shoulders, over hips. and really sort of focusing on the scapular depression, so shoulders down if we need to, proper like scapular, thoracic, and scapulohumeral rhythm and movements. Such a big fan of using the wall, and there's a lot of other options, but those are two of my favorites.
And Doc, what about you for functional training?
I mean, let's say that we're reaching up and we can only get, this high without getting pain. Then I'm like, you know what, let's go right up to that point right before you have pain. Let's do that for a week. And let's see if we can get, a little higher. Maybe that's 5 to 10 degrees higher a week before you have pain. And that's working the muscles and getting it stronger. Or let's add a 1 or 2 pound weight to represent, you grabbing, a can of soup out of a cupboard overhead. So it's kind of working that. You can add, light weights, because if you're having pain just reaching overhead, then, that's all we need to be able to accomplish. Obviously, you want to be able to accomplish more, but that's a step in wherever your end road is. Someone's writing about exercise for tennis. If that's functional for you, I like to do, if we're serving overhead, I like to do a lot of strengthening overhead. I like to kind of do some perturbations where their hands may be overhead and you're kind of moving their arm around and they have to stabilize because they're going to be swinging that racket. And when the ball hits the racket, there's that perturbation where you need to have your muscles be able to stabilize over in that overhead position, or working eccentrically where the muscles in the back of your arm and your back are controlling the slowing down motion. So I'll do some cable stuff there. So
I love
functional,
that.
again, it's going to be very different individual to individual.
I agree. So Joanne asked, can you mention what are considered contraindicated exercises for the shoulder, i.e. the upright row, inherent bad? It hasn't seemed to be very functional exercises. So what are some exercises that are contraindicated that we just don't like to do or shouldn't do, especially with general public? Sarah?
Well, I think it is very dependent on the person that we're seeing. Like, we may see someone who works at, in a warehouse that has to do specific movements that may be considered contraindicated. So I think it can be really tricky. But things that I tend to stay away from, behind the neck lat pull downs, and anything that could be causing a greater impingement, especially if someone is coming to us with an impingement or an issue of compression. I hate to sort of rule things out completely because it depends, but.
No, I agree with you completely. What about you, Brian? What do you feel is contraindicated that we should maybe, stick away from, especially in a group setting, perhaps?
Yeah. I'd probably just change the word contraindicated to more risky than there is reward out of it, right? So I think as Sarah was kind of alluding to, is she doesn't necessarily classify things as good or bad. It's rather about like, are there other alternatives I could do that have a lower chance of causing a problem? And so it's not that upright rows are bad, but there's probably bunch of other things I could do, like just a simple lateral raise with a dumbbell is probably sufficient in getting most of what we're trying to get done with an upright row, right? People are doing an upright row because they can load it up pretty heavy, right?
Right.
And I want to go back. There was a comment in there I just wanted to touch on about the perception that we might be writing off anyone who's older as being non-athletic. And apologies if it came across that way, because it's not the case at all. I think it's just a matter of us thinking about who might be that, and this is probably a bit of a bias, who might be the average person within a group exercise class. And so, but even when looking at the athletic older adult, all right, even the competitive ones, I don't think the programming and the exercise selection necessarily changes, right? We're just adjusting loading parameters along the way. So there's a lot more similarities than there are differences across that continuum there.
I love that. Dr. Collin mentioned that the incidences of rotator cuff increase with age from a prevention POV. What stretches should be built into a diverse group exercise class?
Yeah, I was actually just typing a little response to that. I wouldn't say it's necessarily something that stretching can help. It's just because over time, if you think about, like, I have a lanyard here. Let's say this lanyard is your rotator cuff, your supraspinatus. Well, eventually that's going to kind of get worn away. And so it's not so much a stretch thing as we need to strengthen that muscle. Because eventually if you keep wearing away, you're going to get through all the layers of fabric or your muscle or tendon, and it's going to kind of wear it through. So it's not so much a stretching thing as specifically targeting supraspinatus, infraspinatus exercises, more strengthening.
And Brian, you had said something previously about the flexibility, and yours is like, what's the end game for it? If you'd like to elaborate on that a little bit.
Yes, I think we were talking about how much flexibility is needed. And, you know, I don't want to keep going back to the whole thing of it depends, but it depends, right? And, you know, we can look at the different movement screens and what might be considered normal or ideal range of motion. So for example, 180 degrees of shoulder flexion or 160 degrees of shoulder flexion in the absence of thoracic extension. So I think there's kind of two things there. One, does somebody have the ability to get there? Meaning, does their bony structure and joint structure allow it? And if so, then do we need to get there? Meaning if they have no desire to do overhead squats or, you know, swim the breaststroke and all they care about is grabbing a can of baked beans out of the cupboard, then, you know, not having full range of motion may be sufficient relative to the other things they need to work on to make themselves healthy. So if it's going to take me, you know, 20 minutes a day of them doing some stretching exercises, but the other option is for me to have them do 20 minutes a day of walking, I might make the decision to have them do the walking instead of the stretching because that might be more beneficial for them. So there's always this trade-off, right?
And I want to just communicate with them as well. Like people are saying, I believe the speed of the exercise can be contradicted, and you're exactly right. We all know, even with group fitness or PT, show me that you can do it with a minimal weight, and we can load if we decide to. It's the end game. But of course, the safety of the movement pattern is what we're always looking at. So even an upright row, somebody says an upright row bad, depends on the alignment where you bring the hands up on an upright row. You can go, I don't normally go here in a group setting. I'm always going to go in alignment with the shoulder. So once again, just think old school of like alignment issues. And you're right, speed is definitely a thing. If you're using music as your motivation for movement, you have to slow it down, especially with weights. It depends on what size weights you're using, of course, like anything else. Sarah, do you want to add to that or thoughts?
Yeah, and I think, you know, with regards to kind of Group X, you just thinking about as a whole, like, are you getting some loading of the hands? Are you getting some scapular retraction? Are you getting some, you know, pec stretching? Are you getting some of those overall kind of movements? Yeah, just kind of like, I think in general, taking a step back and looking at the big picture could be really helpful.
Right. Doc, Pam wrote something in I'd love for you to answer. I'm having another arthroscopy and now a rotator cuff, tendon repair. I told the first surgeon something wasn't right. Meanwhile, the new surgeon said you shouldn't do planks and after rotator cuff surgery. I don't really feel anything in my arm shoulder because my strong abs, spinal stability. I have a rotator cuff repair in 2001, I do believe I can do planks. How do you feel about that? Rotator cuff repair and planks.
I feel like that really oversimplifies it. Because I mean, yeah, you want to have the stability, you know, in that playing position, but yeah, there's a lot of other stuff going on, and you got to consider how long does it take for the tissue to repair. You can't just go from having a surgery, a rotator cuff repair, to doing planks the next day or a week. There's a whole process with that. So I feel like that's super oversimplifying it. Of just get a rotator cuff repair and do your planks. But if, yeah, I'm reading that message now. I mean, I think it's great to do physical therapy, and obviously that's my job, and you know, I'm gonna believe in the profession, but I don't see really where you can go wrong doing physical therapy after a rotator cuff repair. And if you get discharged earlier because you're making great progress, great. I always feel like with so many surgeries, and you don't need physical therapy for every surgery, but you know, your most of the way there, you might as well go that little extra bit and go get strong and get that stable base, especially if you're active teaching yoga and Pilates and spin. So
I love that. Okay, so somebody just asked, when doing a shoulder press, is it better to have palms facing each other or palms facing outward? So when you're doing a shoulder press, do you like them here or here? Where do you like, Brian?
Yes, if you're looking for the lowest risk, lower challenge of anything going wrong, then you'd probably go into that kind of scaption, right? Or elbow out to the side a little bit and moving through that range of motion there. With that said, there's nothing wrong with being arms out wide, and there's nothing wrong with being in here, right? Just this one's going to allow the joint to be in its most open position and reduce, probably provide the lowest risk of anything getting smushed down.
Sarah?
Yeah, I tend to sort of start with like a palm in position just because I find that it can be a little bit more neutral for the shoulder. And sometimes it's just a matter of putting people against a wall, again, like doing the shoulder press against the wall where we're ensuring that they aren't leaning, they aren't compensating, just maybe utilizing other strategies to help them with their form and their execution. Maybe it's not a matter of just the palm position, maybe it's a matter of, C-spine, T-spine alignment in general.
I love that. I love that. Kathy's asking about pain at night. Hanging body weight, scapular retraction has helped me stretch out, which is getting compressed when lying on your side. Do we like that idea? Brian, Doc?
Anything that
I would
makes you feel
want
better is
more
good.
context.
Pardon?
I would want more context, I guess.
Okay. And Brian?
So I'm a fan. If it makes you feel better, go ahead and keep doing it.
I agree with that.
Yeah.
Okay, how about a reverse shoulder replacement and building strength so arm can reach overhead? Wow, Rita, that's a big one.
That's a doozy.
That's a very complex question. Anybody like to take that one? Brian?
I agree. You need more strength. That's why they kind of went with reverse shoulder replacements. Is because they figured out that you get better kind of line of pull from the muscles, and so it requires kind of that a shorter amount of time to build up the strength, just because based on geometry it gives you that little longer lever. But yeah, I mean, after any kind of shoulder replacement or rotator cuff surgery, or you're probably going to need to work on strength a little bit.
Good.
Reverse shoulder. So shoulder is ball and socket. With a regular shoulder or traditional shoulder replacement, they'll kind of cut right there and replace the ball with a metal ball. But with reverse total shoulder replacement, they make now the ball right here and then kind of the socket on the outside.
Okay, and then somebody asked, thoughts on working with clients who have degenerative issues in the shoulder, rotator cuff, cervical spine, what to add in or what to avoid? Sarah?
Well, I think keeping in mind, that progressive overload is really important. So start at the start where your clients are, assess movement, take a look at where they need to go, build up slowly from there, whether that's, rotator cuff, scapular stabilizers, range of motion, and think about alignment. Like oftentimes we forget about the C-spine in our shoulder exercises. So if we're doing something supine, is the shin sort of tucked in? Is the C-spine aligned with the T-spine? Standing, seated, same thing. Like look at that alignment, ear over shoulder. Think about that sort of, stacking, if you will. And in general, if something causes discomfort, maybe you don't need to change the exercise. Maybe you just need to tweak the execution or the form, or add in maybe some scapular depression, like maybe shoulders down or head back. Is going to reduce some of the discomfort.
I love that,
And
Brian.
if something feels good, go for it.
What do you think, Brian?
I had a wonderful thought. It escaped me. So I'll go with another. Oh, I remember where I was. This is where I think Colin had mentioned it earlier with some of the isolation exercise for folks. I think this is a time and place where some isolated rotator cuff activity would do well in some of these degenerative conditions. But then to kind of expand on some of the stuff that Sarah was saying, there were kind of two things I heard that I think we could explore a little bit more. One on the idea of, right, using proper technique, right? But then also this idea of symptom modification, whether that be through head position or arm position. And sometimes I think it's hard to reconcile those two, because there may be cases where somebody tries to bring an arm overhead and it's painful, that the symptom modification might be allowing that shoulder to elevate. And I think in that case, that shoulder elevation with flexion is okay. But I think what's been drilled into us over the years in a lot of places is that, you know, you can't ever let that shoulder elevate. Always got to work on scapular depression. And I always come back to, well, maybe, like if it feels better for somebody to do it that way, I'm probably not going to change it. I might wait for them to get out of pain. Now, even if somebody doesn't have any pain, right, how important is technique? And I think that's a big loaded question, because I think faster speeds and heavier loads technique may become more important under some conditions, but in some cases, technique might not matter as much. And I'll pause there and can always go deeper if you want.
Colin, do you want to add anything?
I don't think I have anything to add. I think those were great answers.
Okay, well then somebody just asked a great question, which is, for my bionic shoulder, 5 anchors, when I have had PT many times, heavy emphasis on posture, any postural exercises you routinely use? Dr. Colin?
I like stretching out your pecs. So whether that's going into a doorway, and I'm going to adjust my screen here, but kind of having your shoulder at like kind of a 45, 60-degree angle, 90 and kind of 120. Stretching out all the directional fibers of your pecs is important. So I like to do that in a corner. I like to lay on a foam roller and just doing some snow angels, because your pecs are going to attach to your scapula, and that's going to change. If that's tight, that's going to kind of change everything positionally. And then with us forward on our computer all the time and on our phones, our head comes forward. So I like to do a little kind of retracting the neck and tucking the chin a little bit. The whole kind of like imagine the string coming out of the top of your head type things.
Sarah, what about you? What postural exercises or do you like to use for this?
Well, I love the wall exercises, because I think it gives us the feedback of what structures should be touching and how to get into that optimal alignment. But to sort of move away from that, we can sort of use different strategies like, dowels or foam rollers. Like if we're in a quadruped position, laying the roller across the spine or the dowel, you get a sense of, okay, is the head moving away from the dowel? Can we get the head back touching the dowel? Because we're not going to be stuck against a wall, or, we want to sort of be able to progress and integrate. So thinking of different tools to help us, work towards the same end result.
And Brian?
I don't really care about it much anymore.
What do you mean?
Meaning, I think if there's a certain posture that I want to have for a movement, that would fall under the realm of technique, right? Somebody squatting with a heavier load, than the posture of maintaining a lengthened spine is important to me. But listen, as I'm sitting here at the computer, when one position gets tired, then I change to a next position. And sometimes that's slumping with my head forward, and sometimes that's sitting up tall with my neck back. And I think this falls under my belief of build comprehensive capacity. And sometimes that's comprehensive capacity for crappy posture, and sometimes it's comprehensive capacity for what would be considered good posture.
I love that. I love that. So we're actually running out of time, guys. So I'm going to ask one last question on my panel. How can I train a client who has had a prior shoulder injury? How can I train a client that has a prior shoulder injury? Brian, do you want to finish it?
Sure. So I think we can tie together a bunch of things that we've already talked about, right? So somebody comes in with a prior shoulder injury, we got to find out if they're in pain or if they're not in pain. If they are, we're going to do symptom modification if we can, through positional changes, or through loading changes or speed changes, or any of the other things that we could do to help make that feel better. And then we'll probably start out with a few more isolated activities, build into the integrated activities, go from lower loads to heavier loads, find out what their goals are, try and build some capacity that slightly exceeds their goals so they have a little bit of a buffer, and then make sure you're layering on all the other kind of healthy behaviors on top of this, because it all works together.
I love that. How about you, Sarah?
Yeah, I think it starts with a full sort of history or understanding, the injury, and just kind of breaking things down, like looking at patterns and really trying to identify, where are the potential cracks in the foundation, avoiding compensation. So if you're seeing a lot of overuse of some areas, maybe try sort of down regulating those overworking areas with rolling or stretching before up regulating some of those underworking areas. And just in general, good alignment and good connection. And sometimes less is more. So if we're, trying to work on the scapular retractors and you're asking your clients, what do you feel? And they're like, yeah, I just feel my neck. Well, you may need to decrease the load short term, like stay within their threshold until they can get those solid connections and movement patterns before kind of building and progressing purposefully from there.
I love that. And how about you, Doc?
I like everything that Brian and Sarah have been saying. Just adding on to that is kind of understanding the injury and how long ago it was. If someone dislocated their shoulder 30 years ago and it kind of went back in on its own, or they didn't need surgery or anything, I'm not going to be as concerned about that as maybe they have a labral tear that's they've had forever and it's starting to cause issues for them.
I love that. I love it. And you guys all probably agree that asking, when you're training someone, to ask them to bring their sheet from their PT so you can see actually what's going on and what they've been working on. There's nothing wrong with that. And Diana asked a great question. What do you think about using bands compared to using dumbbells? Brian?
I don't think the body cares, right? It's just load, right? So I think I would say 20 years ago, I would have said, well, you don't want to really use bands because the resistance increases and it doesn't follow how the muscle works, whatever, right? I just want people moving. So if I have a choice, right, I think it would depend on, for some people, they don't like doing, they might not be able to get into the right position in order to load the tissue the way I want. So sometimes the hard thing is on, if I'm going to do an external rotation, isolated external rotation with a dumbbell, I'm going to need to get them sidelined. But if somebody can't get down on the ground very well, then an elastic band is fantastic. They're portable. So I have no problem with one over the other.
Sarah, do you want to add anything?
Yeah, I was just going to say, maybe more important than the type of load is the vectors that we're using. So if we're working with someone who typically spends more time down here versus up here, spending more time in the vectors and lines of pull that our clients maybe need a little more robustness or are spending more time in.
Great. And do you want to add anything, Doc?
Yeah, sometimes I like bands because it creates a little more instability because there's that changing amount of load. And I can sometimes very easily change where that load and resistance is coming from. So it depends kind of what I want to get out of it.
And communication, guys. It's always about communication with our clients, and we all know that. Ask them what they're feeling. Does it feel okay? Does it not feel okay? And they're going to come in sometimes and say, my shoulder hurts. Guess what? Brian made a very good point. And guess what? Let's do the other parts of the body. And hopefully with time, we just need some rest. Sometimes we've just overused the muscle mass. And so my last thing is, we've got 2 minutes to sum it up. Let's say you're not comfortable with training. Somebody comes to you and it's out of your wheelhouse. What do you like to do about that, Sarah? If somebody comes to you and they're like this, my background, for instance, if I came to you and I don't have any background in shoulder prevention of anything, what would you do as a trainer, I guess?
Well, so as a coach, I own a multidisciplinary clinic and love the fact that I could just say, here, go see our AT, see our PT, see our RMT. I think, and this was something that I did early on, I've been doing this for 22 years, referring and having a big circle, a big network. And I have I just think it's important to refer out. And a lot of times we think, oh, we're going to lose that client. They will come back. It all comes full circle. Like the client eventually does come back. I think, and they come back with their friends because they're like, yeah, this person referred me to someone amazing, and they stayed within their scope. And I think that's important.
I love that. How about you, Doc?
Yeah, I love going and observing and shadowing people. So whether it's other PTs, ATs, personal trainers, strength coaches, I love going and observing and talking with them and finding out, why do they do things the way that they're doing them? And maybe it's something that I had never considered. And then that kind of builds your local network of, hey, like if I have someone that's limited to 12 PT visits a year and they need more stuff, they're doing ACL rehab, well, now I have a strength trainer or like a strength coach or a personal trainer that I can send them to, and I can check in with them every month or so and know that they're taken care of. So it's nice to build that network so that you can refer to whoever you need to refer to.
And Brian?
Well, I'm going to be a politician and not answer your question at all. I'll close with two other things. I think the first one is that I think what you'll see is that there's a lot of similarities in what we're talking about. And even though there's differences, and we could probably find, 30 different ways of approaching this, most roads lead to Rome. You just got to work within the capacity of the person. So rarely is there an absolute right or wrong in these things. I think that's the key thing that I would probably want to put out there.
I love that. Well, you guys, we are out of time, and I don't know about you guys that are listening in, but I learned a lot tonight, and I hope you feel the passion and the professionalism that you felt from the panel like I did. I am honored, you guys, for what you've told us tonight. I want everybody to type in if they have any more questions, if you don't mind, how they can get a hold of you once again. Don't forget, next Tuesday, there'll be another webinar. I want to thank Sarah, Dr. Colin, and Brian for just bringing your expertise and your passion, and just, you're so good at what you all do. And thank you guys for at home listening in, because it just shows us that you're wanting to know more. And I loved your questions tonight, because sometimes we don't hear anything, and you have a lot of questions that I hope we helped answer. And once again, if not, let us know what else you need. I want to thank everybody. I want everybody to have a good night. It's hot where we are, so stay cool, except for Sarah in Canada. Have a good night, guys. Thanks, everybody. I appreciate you. Take care.
Thank you.
Thank you.
Good night.